My talk is to be looking at the reviving the cushion and looking at meniscus allograft transplantation. So we've talked about this a little bit before, so I just want to go briefly over the anatomy and why this is important and how you consider what you need a meniscus transplant. So the medial meniscus covers about 50 to 60% of the plateau. It's C-shaped, it's not mobile, right? So it is really connected to the capsule. Lateral meniscus covers about 70 to 80% of the plateau and is much more mobile and it's much more circular. So when you look at the anatomy, it's really important to understand the relationships between each of the structures. The posterior root is very close to the PCL, whereas the anterior root is much more almost off the plateau, if you will. The lateral meniscus, the posterior root, you can see it's C-shaped, it's round, so it's very close with the posterior root and anterior root. And you can see that the anterior root, as we talked about with other talks, is very intimate with the ACL itself. So why is this important? So the anatomy does translate to the biomechanics. So the lateral meniscus, since it's C-shaped, round, and it covers up most of the plateau, it does carry the load of the entire lateral compartment. On the medial side, because the meniscus is only about 50% of the surface area, the load is carried by the meniscus and the cartilage. And this is why you have to consider why a meniscus transplant, why do you want to do it? So when we have subtotal meniscectomies, we can decrease that contact surface area. So if imagine, it just concentrates all those loads into a smaller area. And then what happens is you have exponential increases in contact pressures, which will cause degradation, right? So you're talking about up to 235% increases in contact pressures. A lot of talks earlier looked at how meniscus is important for joint stability, so it's a significant secondary restraint to anterior translation. And then also for the lateral meniscus, it's really important when it looks at rotational stability. So let's put all those pieces together, the anatomy, the biomechanics, and understand that if you've taken out the meniscus, what can happen is patients will have overloaded that area, right? They'll start having effusion, they'll have compartmental pain, and we have to really consider all the other factors that can really add to all those contact pressures, right? Is there coronal malalignment? Is there ligamentous stability? When you look at ACL reconstructions, you want to see why did your ACL fail? Was it because of an issue with the meniscus? So this now takes us to our indications for meniscus transplant, which is a young patient, 50-ish, and that number keeps on changing as I get older. But we're looking at also localized joint line tenderness and pain, not significant osteoarthritis, so not significant loss of that joint space. So KL less than or equal to 2. The mechanical environment has to be optimized, so looking at coronal alignment and ligamentous stability. BMI less than 35. But most importantly, patients have to have realistic expectations. This isn't perfect, but this is a good stopgap to what's going to be in the future. So these are two patient scenarios that I've had. So I have a 45-year-old male. He had a left ACL reconstruction that I put an allograft in because he wasn't really high demand. And I had to do a subtotal meniscectomy for an acute or chronic knee injury. He did have medial joint line pain that started about 3 months post-op and just wouldn't get better even after significant rehab. Patient also stated that when he was doing activity, especially going downstairs, he would notice this subjective instability that he said that was an emptiness on the medial aspect of his knee. This is my 19-year-old female patient who was playing flag football. She was a prior competitive soccer player and underwent a prior ACL reconstruction, was able to return to play and had a meniscus repair, but then had to have that meniscus trimmed out. So when she came to me, she presented with her knee dislocating, is what she described it, but she also had medial-sided knee pain. So when you evaluate and you work up your patient, this is like standard how you look at any of your patients, right? You want to know the history. You want to know what symptoms they have, prior surgeries. If you can get your hands on their arthroscopic images, that's always helpful for you to put the pieces together. When it comes to physical exam, you want to do a comprehensive physical exam, right? The meniscus meniscus insufficiency doesn't exist in and of itself in isolation. You have to look at anything else in terms of ligament stability, coronal alignment. Then you look at imaging. So I'm going to talk about looking at weight-bearing plain films with size marker, and we'll talk about that on the next slide. Scanogram is important to assess coronal alignment. Advanced imaging, such as the MRI here, will show you, is there anything wrong with the ligament, how much the meniscus is really there, is there subchondral bone marrow edema, what else do I have to address? And I would make an argument that a diagnostic arthroscopy is actually a part of the workup in looking at meniscus insufficiency. So this is why we need to get plain films with a size marker, because you have to understand the magnification. So using the Pollard technique that was developed in 1995, you look at what is the size of the meniscus off of x-rays. So if you look, medial lateral makes sense, right? It goes to the eminence up to the edge of the metaphyseal margin. But then from an AP standpoint, for medial meniscus, it's about 80% of the sagittal plateau. Whereas you look at the lateral side, it's probably about 70% of the sagittal plateau. So Why does that matter? So Bob Burke's group out of Utah looked at what happens from a biomechanical standpoint if you undersize or oversize your graft. So if it's 10% larger, so you've oversized it, what happens is you have increased contact forces on the articular cartilage. It's almost as if you don't really have a meniscus in there, right? Because now all the forces go through the cartilage. Now, if the meniscus is too small, right, so you've undersized it, now you have a tremendous force on that meniscus itself. And if you can think about it, if all those forces on the meniscus, your meniscus is probably going to fail. So it's important to get it just right. So the other part you want to look at is how is the allograft prepared? So there's different options. Fresh certainly gives you more viable cells, but it's very difficult from a logistical standpoint to do this. It's procured, you have to procure it within 12 hours of the donor's death. You have to implant it within 4 to 6 hours. And reality is, how do coordination's impossible, and there's disease transmission, right? Fresh frozen is probably the mainstay of what we use, the gold standard. The allograft is frozen in an antibiotic solution and can be up to about 5 years on a shelf life. Cryopreserved is another option where you you save the cells a little bit by minimizing cellular damage during freezing, but this can be certainly expensive, and then the question is does that cryopreservant cause any issues with tissue as you implant it? When it comes to surgical techniques, there's different options, right? Dealer's choice. You can do soft tissue, you can do bone plugs, you can do bone trough, right? The idea of having bone is to really keep that enthesis tissue, because anytime when you look at a tissue engineering standpoint is how do you get that tendon to bone healing? How do you recreate that enthesis? And by keeping a bone plug or trough, you have that. For a bone trough, you can see that you actually keep that anatomy of that relationship of that posterior horn, posterior root to that anterior root. So this is my technique I do for a bone bridge trough. So it's about 6 to 7 millimeters wide, about a centimeter in depth. You take down the eminence. You want to shave and burr in line with the roots when you look inside the joint. And then using a device, you can drill to the posterior plateau. Then looking at the box cutter, you want to put that box cutter parallel to the tibial slope. You don't want to change the slope when you put your graft in. And then you slide your bone into that trough. And then you do your fixation standard as you would do regular meniscus pair to the capsule. The important thing I think with the bone trough technique or bone bridge technique is to take down that eminence. Jason had showed a little bit about doing a reverse notchplasty and taking out the eminence itself. When you kind of create that bone trough, you take out the eminence, but on your graft, you probably need to take out that eminence so you can actually pass your graft in. But also, even if you get your graft in later on, this can cause a problem and actually cause adjacent wear to the condyle. So it's important to take down that eminence. When looking at soft tissue or bone plugs, this is kind of a root repair, and this is probably what we're going to see from other techniques later on today. So what I did here is to make that bone tunnel, and then I really am aggressive about decorticating that plateau right adjacent to that tunnel. You prepare the peripheral capsule, preserving about 2 millimeter remnant on the rim, because you want to keep some of those hoop stresses in place. You want to keep kind of that corset or binder to try to prevent meniscus extrusion. I usually use 2 passing sutures just to give me a different axis of pull, and then you put your graft into place. So if you look there, I actually do a technique where I kind of create a bone waferlet, if you will, so just a little bit of bone, and what happens is I can then seat that really nicely and get that bone-to-bone healing. And then when it comes to securing your graft, whatever technique you like, inside out, outside in, all inside. In general, for meniscus transplants, you're going to be using all 3 techniques to get that graft fixed. When it comes to rehab is super important because how well you do from anything is really dependent on how well the patient rehabs. So I'll do a patient will be touchdown weight bearing for about anywhere from 2 to 6 weeks, depending on what other concomitant procedures I've done. Full weight bearing is expected around 6 to 8 weeks post-op. Range of motion, I do limit them initially just to kind of decrease that shear forces along the meniscus as I want that meniscus to heal the capsule. So the key is actually no weight bearing flexion for about 8 weeks. In terms of outcomes, everything is variable. The outcome itself of how successful your meniscus is completely variable. Is it reoperation rate? Is it integration? Is it patient-reported outcomes? So it's really hard to compare apples to apples, and that's what makes meniscus transplant interpreting the literature so difficult. There's also variables of what else was done in the joint, right? So if there's ligament issues, how does the chondral surfaces look? Was there coronal malalignment? Those are all different factors that come into play. The graft itself, medial and lateral compartments are different. Sizing of the graft is important. Did you oversize? Did you undersize? And then how the graft was preserved. Surgeon experience is something that's also always comes into play, right? The more you do, the easier it is, the better outcomes you have probably. And then when it comes to rehab, restrictions post-operatively and return to play do have an effect on outcomes and success of a meniscus transplant. Ultimately though, we don't know is that does the meniscus allograft transplant prevent future osteoarthritis? And that is the million-dollar question. So let's knock out a couple of these variables, right? So medial versus lateral. So in 2006, Verdonk said that the medial side does better. That same year, Brian Cole's group said the lateral side does better. So who knows what the answer is? So a systematic review looked at both midterm survival, so around 5 to 10 years, looking at both medial and lateral. You can see the outcomes are very similar at 5 years and at 10 years. But there was better pain and functional improvement on the lateral compartment. So lateral probably does a little bit better. When it comes to pain and function, Tim Spalding's group out of Coventry looked at 1,300 patients, and this is about midterm follow-up for about 5 years. So all the numbers go up, Lysholm, IKDC, Tegner, everyone gets better, right? But failure rate's around 11%, and chondroprotection is still questionable. We don't know if we can actually stop or halt the progression of osteoarthritis. So let's talk about practicality. So let's see, how do patients go back to work? And in Brian Cole's group, everyone gets back to work. So that's great. Check, next. Let's go to the next thing. How about return to sport? Because a lot of times these are seen in our athletes when they have meniscus tears, right? So systematic review of 9 studies looking at 285 medial, 167 lateral. Average age of follow-up is 31 years, right? So these are younger patients. So about 3/4 of patients will be able to return to sport, but not everyone can get back to their pre-level activity. Only about 2/3 can get back to their pre-level activity. You can see that reoperation rate, which again is different than failure rate, right? So what is our outcome here? Is it failure or reoperation? Reoperation rate's about 13%, but failure, so going straight to arthroplasty, so failure of the joint organ is about 1%. So let's talk about long-term outcomes. So long-term outcomes, maybe like 10 years, 20 years. How long does it take for a meniscus transplant to fail? And so this is 38 patients from the Spanish group looking at, again, all your scores, 60% on the medial side, 40% on the lateral side. Interestingly, most meniscus start extruding, 30% of them will start extrude at 5 years, 73% at 15 years. So we know that this is probably how the meniscus degenerates over time. Joint space also narrows significantly to about 15 years, you're only about 2 millimeters. So that is our osteoarthritis. So mean time to failure is about 18 years for a meniscus transplant according to this study. So let's talk about graft extrusion. What does that mean, right? It's almost like if the graft is almost too big, but what happens is you put a graft that you size well and then now it just spreads out, right? You're squeezing toothpaste out of the toothpaste tube. So this is defined as displacement of the meniscus to the central margin of the plateau. This can be, the issue is the graft is non-anatomic and can lead to biomechanical disadvantages. Interestingly enough though, this has never been correlated to PROs. So in terms of how patients do, but in terms of soft tissue grafts, grafts with bone plugs, grafts with bone troughs, there's no difference in extrusion. Even if you delay rehab, change it, do a bunch of capsulodesis, everything fancy to get that meniscus to stay in place, there's no difference. So stay tuned, we don't know what the answer is. Interestingly enough, this study out of China and AJSM in 2021 looked at 17 knees who had meniscus transplant. And so they actually measured extrusion in more than just the coronal plane. They actually did it in radial planes around the meniscus. And so they classified patients as either non-extrusion grafts or extruded grafts. And so they measured joint space narrowing, cartilage degeneration, and followed them for 11 years. So relatively long-term outcomes, and found that the patients who had meniscus transplants who did not extrude had less joint space narrowing, better cartilage degeneration scores versus the meniscectomy. So a little more hint that this might be chondroprotection. So we still just don't know, but this is a really compelling evidence here. So what's on the horizon? There's an issue with accessibility and availability, right? Getting grafts are not easy. It's not everyone can get them. So this is something that's coming out of Europe. It's in stage 1 trials looking at just safety, but it's a meniscus prosthesis made out of PCU. It's only indicated for the medial side at this time. So we'll see in the next 10, 15 years where this takes us. So these are the patient scenarios. So my 45-year-old male, he had ACL allograft. So what I ended up doing is a meniscus transplant with the trough. And you can see I actually had to go back in because I did not take down the eminence. And then you can see that the meniscus looked really actually integrated fairly well, but it probably extruded a little bit. And then looking at my young female athlete who we ended up doing a meniscus. I did a soft tissue technique with a little bone sliver, and then did an osteochondral grafting. And that's kind of what you see here in addition to revision ACL with patellar tendon. So in conclusion, indications for meniscus allograft transplantations are those who are post-meniscectomized, joint compartment overload, less than 50 years of age. Alignment, mechanical stability, and cartilage status need to be addressed at the time, understanding that meniscus is really important as a secondary stabilizer. We know that there's good to early midterm outcomes, but we still don't know if it's chondroprotective in the long term, and can we actually preserve the joint in the long term. So thank you. Ranawat.